Chapter 20, Endocrine and Hematologic Emergencies. The focus on this chapter will be on diabetes mellitus, bleeding disorders, and clotting disorders. Introduction. The endocrine system influences nearly every cell, organ, and function of the body. Endocrine disorders can have many signs and symptoms. Hematologic emergencies are difficult to assess and treat, and this would be bleeding disorders. So let's look at the review of the anatomy and physiology of the endocrine system. The endocrine system is a communication system that controls functions inside the body. Glands secrete messenger hormones. Hormones affect any organs, tissues, or cells. Endocrine disorders are caused by an internal communication problem. Glucose metabolism. The brain needs glucose and oxygen. So the brain needs a constant supply of glucose and oxygen. However, the brain does need insulin to get glucose. Everywhere else in the body, with the exception of the brain, requires insulin to be present in order for the cells to utilize glucose. Insulin is produced by the beta cells in the islets of Langerhans in the pancreas. Insulin is produced when there is too much glucose molecules in the blood. And the purpose of insulin is to open a door to the cell so that the glucose molecules can move from the blood into the cell so that the cells can metabolize properly. Now, apart from facilitating the movement of glucose molecules into the cell, insulin will also convert excess glucose molecules into glycogen, which is stored in the liver. So, glucose metabolism. The brain needs oxygen and glucose. Insulin is necessary for glucose to enter cells. Exception would be the brain cells. Without enough insulin, cells do not get fed. The pancreas produces and stores glucagon and insulin. Insulin is produced by beta cells. Glucagon is produced by alpha cells. And this is in the pancreas, specifically the islets of Langerhans. Glucagon is going to be produced when blood sugar is too low, or if the body thinks that the blood sugar is too low, because the blood sugar might be appropriate. It's just that the insulin is not working as it should, or it's not present to facilitate the movement, but the body might not know that. But generally speaking, glucagon will be produced when the blood sugar is not sufficient. So what glucagon does is it converts glycogen that is stored in the liver to glucose. That's the purpose of glucagon. Now, let's look at the pathophysiology. Diabetes mellitus impairs the body's ability to use glucose for fuel. And this is the diabetes that we will specifically focus on. There's another one. So there's another diabetes that is referred to as diabetes insipidus. It's more due to diuretic hormone, not something that you need to be familiar with at this stage. The focus really is going to be on diabetes mellitus. Without treatment, blood glucose levels become too high. Complications include blindness, cardiovascular disease, and kidney failure. You need to know signs and symptoms of blood glucose. That is, so a patient who has diabetes mellitus can have issues with high blood sugar, and they can have issues with low blood sugar. Now, hyperglycemia and hypoglycemia can occur with diabetes type 1 and type 2. Now, the patient that has diabetes mellitus type 1 cannot produce insulin. And that is why it is often or used to be referred to as insulin dependent diabetes. So a person with type 1 cannot produce insulin. A person who has type 2, they can produce insulin. However, the insulin production might not be sufficient, or the insulin that they're producing is not working properly. Used to be referred to as adult diabetes. All hypoglycemic patients require prompt treatment. So let's look at them more in depthly now. Diabetes mellitus type 1. It's an autoimmune disorder where the immune system produces antibodies against the pancreatic beta cells. Autoimmune means the body is destroying itself. Missing the pancreatic hormone insulin, without insulin, glucose cannot enter the cell, and the cell cannot produce the energy that is required for it to metabolize. Onset usually happens from early childhood through the 4th decade of life. Immune system destroys the ability of the pancreas to produce insulin. Patient must obtain insulin from an external source, so they have to take insulin, and it can be fast acting, it can be intermediate, or it can be slow acting insulin. Patients with type 1 diabetes cannot survive without insulin. Many people with type 1 diabetes have an implanted insulin pump. Not going to see that a lot in Jamaica. You will definitely come across that outside of Jamaica. It continuously measures glucose levels and provides insulin. It limits the number of times patients have to check their finger stick glucose level, can malfunction, and if it malfunctions, the patient can have diabetic emergencies. And the diabetic emergencies will be either the blood sugar is too high or the blood sugar is too low, hypoglycemia or hyperglycemia, and there are extremes to these issues. Always inquire about the presence of an insulin pump. Still on diabetes mellitus type 1, most common metabolic diseases of childhood. So it's common in the pediatric population. Now, the type 1 new onset patient will have symptoms related to eating and drinking. So you're going to see the 3 P's. The 3 P's are common with the blood sugar rising. So once the blood sugar is rising, you're going to see the 3 P's. And remember what I said earlier. The patient might have enough glucose in the blood, but the glucose is not being facilitated into the cell because the insulin is not present. So maybe they ate and they didn't take the insulin properly, or they forget to take the insulin, and the glucose molecules are building up in the bloodstream. And this will produce the 3 P's: polyuria, polydipsia, polyphagia. Polyuria is excessive urination, so the body is trying to get rid of that excess sugar. And the urine is going to have a dark color. Polydipsia is excessive thirst because the glucose molecules are pulling water out of the cells. So the cell starts to shrink and become dehydrated. Polyphagia, excessive hunger because the cell's not getting the glucose. The patient can have weight loss and they can have fatigue. Now, a normal blood glucose is between 80 to 120 milligrams per deciliter. So in the States, they use milligram per deciliter. In Jamaica, we use millimoles per deciliter. To convert milligrams per deciliter to millimoles, you simply divide by 18. And that will give you millimoles. And to convert millimoles to milligrams, you multiply by 18. So milligrams is common in the US. In Jamaica, you're going to see millimoles, more common. For your exam questions, you will not see a blood sugar in millimoles. It will always be in milligrams. For your practicals, I will not give you a blood sugar in millimoles, or no instructor will give you a blood sugar in millimoles. It's always going to be in milligrams based on the curriculum that we're using. When a patient's blood glucose level is above normal, the kidney's filtration system becomes overwhelmed and glucose spills into the urine. When glucose is unavailable, the cells in the body turns to fat. So this is very specific to a type 1 diabetic. So a type 1 diabetic has eaten, they have had some food, but they have not taken any insulin, or they're not taking insulin. The blood sugar, so glucose molecules, builds up in the blood. So it starts to build up in the blood, but it cannot enter the cells. So the cells are still demanding glucose. The body senses that, right? So the brain senses that. And what the body will do at that point is it will activate glucagon. So it activates glucagon, and glucagon is going to convert glycogen to glucose, and then we have more glucose molecules building up in the blood, but it's not reaching the cell. Still not reaching the cell. The cell needs the glucose. The body senses that. The body is going to take extreme measures now. So the extreme measures that it's going to take is it's going to start to break down fat in the body for energy. And when the body starts to break down fat, we start to get acid waste known as ketones. As ketone levels go up in the blood, they start to spill into the urine, and the kidneys cannot maintain acid-base balance. So the body starts to develop acidosis, diabetic ketoacidosis. These patients will start to breathe faster and deeper. We call it Kussmaul respiration. So it's going to be fast and deep, and it will have an unusual odor. It's not that their breath smells bad, but it has an unusual odor. Most persons describe it differently. For me, it smells kind of like nail polish removal. That's what it smells like to me. And this is unique to type 1. So again, with your type 1 diabetic, they don't produce insulin. So if this patient eats or consumes food, they have glucose molecules building up in the blood. So the blood becomes hyperglycemic. However, these glucose molecules cannot reach the cell without insulin. So the cell's not getting the glucose. The body senses that the body has to do something. The first thing the body will do is activate glucagon. Glucagon will convert glycogen in the liver to glucose. We now have more oxygen molecules building up in the blood, so the blood sugar continue to rise. However, enough insulin is not there to facilitate the movement of that glucose. So the cell's still not getting the energy it requires. The body takes extreme measures at that point and start to break down fat. When the body breaks down fat for energy, we get a byproduct, an acid waste byproduct, ketones. Because it's acidic in nature, then the patient will develop acidosis. And the body tries to compensate for that diabetic ketoacidosis by breaking down the acids into carbon dioxide and water. So they're going to breathe faster and deeper, and you'll have that unusual odor from the ketones on the breath. That's diabetic ketoacidosis. It's unique to a type 1 diabetic. Now, if fat metabolism and ketone production continue, diabetic ketoacidosis or DKA will develop. May present as a generalized illness plus abdominal pain, body aches, nausea, vomiting, altered mental status, or unconsciousness. Now, please note that DKA will only occur when the blood sugar rises for a type 1 diabetic. Now, if a type 1 diabetic doesn't eat enough and takes their insulin, and the insulin facilitates the little glucose that is present, then they won't have enough glucose in the blood for insulin to move, and the blood sugar falls. That's hypoglycemia. Now, if the blood sugar drops, the changes that occur will be rapid in comparison to when the blood sugar rises. And it can be deadly. So a low blood sugar that is not corrected can be deadly very quickly. And that's how this patient would get hypoglycemia, which is low blood sugar. And eventually, you might see the term insulin shock. All that means is there's too much insulin, not enough glucose in the blood. Hold on, let me backtrack a bit. All right. Yes. Still on type 1 diabetes mellitus. If not recognized and treated, DKA can result in death. Obtain a glucose level with a finger stick using a lancet and a glucometer. Generally, their blood sugar is going to be higher than 400 milligrams per deciliter. So DKA, diabetic ketoacidosis. The signs and symptoms will gradually occur. And remember to convert milligrams per deciliter to millimoles, you simply divide by 18. And if you have the numbers in millimoles per deciliter, multiply by 18 to convert them to milligrams. All right, so that's type 1 diabetic. So the type 1 diabetic have several issues. If they're having DKA, the blood sugar is too high and the body is utilizing fat for energy. So what is going to happen is they have acidosis to deal with, which messes up electrolyte flow, the flow of electrolytes within the body. And because of the excess sugar, they will become dehydrated because that sugar is going to pull water out of the cell. So they have acidosis, that is an issue, which messes up the electrolytes. They're going to need insulin, and they have issues with dehydration because the excess glucose molecules is pulling water out of the cells. Cells are becoming dehydrated. Now let's look at your type 2 diabetic. So type 2, diabetes mellitus type 2. Now remember, this is your patient that is producing insulin. However, the insulin might not be working effectively or it might not be sufficient. So it's caused by a resistance to the effects of insulin at the cellular level. Obesity predisposes patients to type 2 diabetes. And if you think about it, you would understand why. So a patient that is obese, they have a thicker layer of cells. And because of the fatty layer of cells or the thicker layer of cells, it's very difficult for the insulin to move through that thickness and get to the cell. So they are at risk. The pancreas produces more insulin. Insulin resistance can sometimes be improved by exercise and dietary modification. So these are your patients who you'll find that they are most commonly placed on medication. They can be on insulin, but more commonly they're gonna be on a medication, oral medication. So oral medication used to treat type 2 diabetes, injectable medications, they can be on insulin. It's not common though for them to be on insulin. So medications and insulin can be used for type 2. Now, with your type 2 patient, because the body is still producing some amount of insulin, it means that, or the insulin might be functioning but not effectively, it means that some amount of glucose can get into the cell. It's just not getting enough. So what that means is, for a patient with type 2, as their blood sugar rise, their body will not break down fat for energy because there's some amount of glucose that can get in the cell. So a type 2 diabetic, the most significant problem that they're gonna have as their blood sugar rise is dehydration. So they're gonna have significant dehydration and they are at risk for going into a coma, diabetic coma as it is called. All right, hold on. Okay. Still on diabetes mellitus type 2, often diagnosed at a yearly medical examination from complaints related to high blood glucose levels, including recurrent infection, changes in vision, numbness in the feet. Diabetes tend to affect functions of various systems within the body because we have cells all over the body, and all of these cells need glucose. And if they're not getting it properly, then they can't carry out their function. So it can cause a lot of problems with various systems within the body or structures within the body. Now, symptomatic hyperglycemia. Please note whether or not the patient has diabetes mellitus type 1 or diabetes mellitus type 2, they can have hyperglycemia and they can have hypoglycemia, depending on what they do. So, looking specifically at hyperglycemia, this occurs when the blood glucose levels are high. The patient is in a state of altered mental status resulting from several combined problems. Now, for your type 1 diabetic or diabetes, this will lead to ketoacidosis and dehydration from excessive urination. We already looked at that. So your type 1 is the person that is utilizing their body fat because their body cannot produce insulin. Type 2 diabetes will lead to non-ketotic hyperosmolar state of dehydration. Don't make that big word make you get nervous. It simply means that the patient has extreme dehydration. So type 2 diabetic will have extreme dehydration. They don't have any acidosis because they can still produce some amount of insulin, or because the insulin is not completely not functioning, some amount of glucose can get in the cell. So when you see that big term, non-ketotic state of dehydration, or you might see hyperglycemia, somebody's microphone is on. Or you might see the term hyperglycemic, hyperosmolar, non-ketotic coma. You see that big word? It simply means that the patient has extreme dehydration. Still on symptomatic hyperglycemia. If an individual has hyperglycemia for a protracted length of time, the consequences of diabetes may be present. So they might have issues with wounds healing. They may have numbness in the hands and feet. It can affect their vision. They can have kidney issues, renal failure, so they're at risk for that. They can have gastric motility problems. Still on hyperglycemia, when blood glucose levels are not controlled in diabetes mellitus type 2, they can have hyperglycemic, hyperosmolar, non-ketotic syndrome or coma. And as I said before, when you come across that big word, it just means that the patient has excessive dehydration because of the high amount of glucose molecules building up in the blood. Now, key signs and symptoms of HHNS include hyperglycemia, altered mental status, drowsiness, lethargy, severe dehydration, thirst. The urine will have a dark color. So when glucose is in excess in the urine, it's going to have a dark color. They can have visual or sensory deficits, partial paralysis or muscle weakness, and seizures. Still on hyperglycemia, higher glucose levels in the blood cause the excretion of glucose in the urine, and this increased fluid intake causing polyuria, excessive urination. Urine becomes dark and concentrated. And if they spill urine while urinating, ants will start to gather around it. Patient may become unconscious or have seizure activity due to severe dehydration. The brain cannot function effectively if it's severely dehydrated. And the brain takes longer than other areas of the body to rehydrate. Now, let's look specifically at symptomatic hypoglycemia. So this is the low blood sugar now. A patient's blood glucose level drops and must be corrected swiftly. So when the blood sugar falls, the patient needs treatment immediately, as soon as possible. When the blood sugar is rising, the changes gradually occur. There's a little time. But once the blood sugar falls, they need blood sugar as soon as possible. So this can occur in patients who inject insulin or use oral medications that stimulate the pancreas to produce more insulin, and there is not enough glucose available. When insulin levels remain high, glucose is rapidly taken out of the blood, and if there is not enough glucose in the blood sugar falls. So if glucose level falls, there may be an insufficient amount of supply to the brain, and the brain needs a constant supply of glucose. Now, still on symptomatic hypoglycemia, they will have mental status changes. The patient can become aggressive or combative or display unusual behavior. They can present as if they're intoxicated. Unconscious and permanent brain damage can quickly follow. They are at a high risk for brain damage. Still on symptomatic hypoglycemia, common reasons for low blood glucose level to develop. They took the correct dose of insulin with a change in their everyday routine. They took more insulin than they needed to. They took the correct dose of insulin, but they didn't eat sufficiently. The correct dose of insulin was taken, and the patient develops an acute illness, which is going to use up a lot of the available resources in the body. Or the illness might affect how the insulin functions. Still on symptomatic hypoglycemia. Now, the signs and symptoms of hypoglycemia include normal to shallow or rapid respiration, pale, moist skin, diaphoresis, which simply means excessive sweating, dizziness, headache, rapid pulse, normal to low blood pressure. Signs and symptoms of hypoglycemia: altered mental status, anxious or combative behavior, seizure, fainting, or a coma, weakness on one side of the body, rapid changes in mental status. Now this diagram is a nice little chart showing the extreme ranges and the normal ranges for the blood sugar. So anything below 80 milligrams per deciliter can cause hypoglycemia or hypoglycemic crisis or insulin shock. Anything above 120, you're looking at hyperglycemia. Above 400, you're looking at DKA, HHNS, or symptomatic hyperglycemia. And I've had patients that their blood sugar is so high that the machine just says high. It doesn't even give a value. It said high. Now, hypoglycemia is quickly reversed by giving the patient glucose. With glucose, the patient can, without glucose, the patient is at risk for brain damage. Again, they need that intervention as quickly as possible once the blood sugar is low. All right, so that's the pathophysiology of the issues associated with diabetes mellitus, which is the inability of the body to utilize glucose for fuel or energy. Let's look at the patient assessment approach for these patients. So complete your scene size up, ensure your scene is safe. Patients with diabetes may use syringes, so be careful how you navigate their environment. Be alert for clues, Use appropriate standard precautions for yourself and your partners. Question bystanders on events leading up to your arrival. Keep open the possibility that trauma may have occurred. Determine the MOI and NOI as necessary. After your scene size up, and also remember that if you need additional resources, request that resource early. So if you think you're gonna need ALS and it's available based on your primary service area and where you're working in the world, request ALS. If it's not available, like in Jamaica, then manage appropriately. Make sure you cover your ABCs and transport to the most appropriate facility. Call ahead that they know what's happening. Now, after your scene size up, primary assessment. Form a general impression of the patient and the environment. Assess airway and breathing. Patient showing signs of inadequate breathing and pulse oximetry levels less than or equal to 94, or who present with an altered mental status, they should receive high flow oxygen at 12 to 15 liters per minute by a non-rebreathing mask. Continuing with your airway assessment, airway and breathing. Hyperglycemic patients may have Kussmaul respiration, a sweet, fruity breath. So this is rapid, deep respirations with a sweet or fruity breath. They can have hypoglycemia. When it's hypoglycemia, that is the issue. They'll have normal or shallow to rapid respirations. So if you can smell an unusual odor on the breath with history of diabetes, you should be thinking hyperglycemia. Now, for circulation, let me backtrack a bit. Now, when it comes to your breathing assessment, we should know this at this stage. We're looking at ventilation, we're looking at oxygenation, and we're looking at respiration. So you need to determine where the problem is. And I'll use hypoglycemia as an example. If the patient is breathing normal and the presentation is stable, no oxygen is required. If the patient is breathing shallow, there is a ventilation problem. So I need to breathe for the patient, especially if it's shallow breathing with a compromised LOC. If the patient has rapid respirations with good ventilation and oxygenation, with good ventilation and oxygenation, and the respiration might be well, not necessarily good oxygenation. It can be there's an oxygenation problem, but the patient has good ventilation. So my treatment is going to be centered around supplemental. So that's 3 different presentations for breathing with 3 different treatments. So again, when you're assessing breathing, you need to think about ventilation, oxygenation, and respiration. And the assessment for that is you assess rate, rhythm, quality, and depth. And utilize your pulse ox. So anytime you're going to give a medical, especially for your medical patients, anytime you're going to give a medical patient oxygen, always ascertain the pulse ox reading on room air before. So get that room air pulse ox. Now, after airway and breathing assessment and management, then it's circulation. Things that you need to think about in circulation: is the skin dry? Is it warm skin? This is associated with hyperglycemia because they are becoming dehydrated. So if somebody starts to get dehydrated, the skin is going to get very dry, skin is going to get very warm. Well, not necessarily very, but they're going to have warm skin. If it's low blood sugar, then the patient is going to have moist, pale skin, hypoglycemia. If it's rapid, weak pulse, that can be associated with hypoglycemia. Now, this slide is not telling you that this is the only thing that you should look for to determine if your patient is hyperglycemic or hypoglycemic. You have to consider everything about the patient's presentation. Now, after your ABCs, what is the patient's GCS? You should know that at this stage. You can also check pupils if you want to at this stage. Is it a load and go or stay in place situation? Do you need to do a rapid scan or a focus? These questions should be answered. Make your transport decision. Provide prompt transport for patients with altered mental status and inability to swallow. Further evaluate conscious patients capable of swallowing and able to maintain airway. After the ABCs, next phase is your history taking. So once you package a patient and put the patient in the back of your unit, if they are able to speak, get your OPQRST as required and a sample. They can't talk, get your vitals, consider your physical findings, consider who is present on the location that can give you information. So investigate the chief complaint. Obtain history of present illness from responsive patient, family, or bystanders. If the patient has eaten but not taken insulin, hyperglycemia is more likely. If the patient has taken insulin but they didn't eat enough, low blood sugar or hypoglycemia is more likely to occur. For your sample history, ask the patient, do you take insulin or pills to lower your blood sugar? Do you wear an insulin pump? Is it working properly? Have you taken your usual insulin dose or pills today? Have you eaten normally today? Have you had an illness or illnesses, unusual amount of activity or stress? After your history taking, secondary assessment is the next phase. Physical examination. Assess unresponsive patients from head to toe. When you suspect a diabetes-related problem, focus on mental status, ability to swallow, and ability to protect airway. Very important. Vital signs, you definitely want to include glucometer reading, if available and protocol allows. Now, I don't think any service should be operating without a glucometer on the unit. Very important device. Hypoglycemia, respirations are normal to rapid, pulse is weak and rapid, and the skin is typically pale and clammy with a low blood pressure. For hyperglycemia, respirations may be deep and rapid, pulse may be rapid, weak, and thready, and the skin may be warm and dry with a normal blood pressure. Now, your portable glucometer, study the operator's manual for proper use in the field. So if you have a glucometer on your unit or in your jump bag, make sure you're familiar with how to use the glucometer. Know the upper and lower ranges at which your glucometer functions. And for adults and child blood glucose level range, we're looking for a range between 80 to 120 milligrams per deciliter. For neonates or newborns, it should be 70 and above. Now, after your secondary assessment, next phase is your reassessment. Reassess frequently, provide indicated interventions. For hypoglycemic, patients who are conscious and can swallow, encourage a patient to take glucose tablets or drink juice containing sugar. Administer highly concentrated sugar gel or glucose gel and provide rapid transport. For the patient who has a low blood sugar that is unconscious, this patient is at risk for aspiration. So this patient is going to need intravenous IV glucose or intramuscular IM or intranasal glucagon. Now, this is an advanced intervention. So this is beyond your scope of practice. And an advance will only attempt to give glucagon if they're unable to get access to a vein. So if they can't get a vein, that's when they'll go for glucagon administration. However, if the patient liver is not working properly, the glucagon is not going to work. And we might get to the extreme as advanced where we need to go directly into the patient's bone, intraosseous. When in doubt, consult medical control. Now, if unable to test for a blood glucose value, perform a thorough assessment, contact the hospital to help sort out the signs and symptoms. During your reassessment, this is also your communication and documentation phase. So you will communicate your findings to the receiving facility and you'll do your proper documentation using the appropriate method that is recommended by your organization. Now let's look specifically at emergency medical care for diabetic emergency, giving oral glucose. So there are 3 types of oral glucose. You have rapidly dissolving gel, you have chewable tablets, and you have the liquid formulation. And what we have out here is a glucose powder. So we have glucose powder out here in Jamaica. Oral glucose, contraindications, inability to swallow, and unconsciousness. So this is a contraindication. Wear gloves before putting anything in the patient's mouth. Follow local protocols for glucose administration. Reassess frequently. Provide transport. Right? So textbook question, contraindication, inability to swallow, and unconsciousness. You can give glucose to a patient that is unconscious, but I'm not going to discuss that right now. For now, contraindication is inability to swallow and unconsciousness. When you come to your face-to-face practical, I'll show you how you do it if the patient is found to be unconscious. So there is a right way to do it and a wrong way. And most EMTs do it the wrong way. Because when the patient comes in, patient face full of glucose, the patient mouth full of glucose, you're compromising the patient's airway. That's the wrong way. So I'll show you how to do it properly when we get face to face. But the answer to the question is, if your patient is not able to communicate and follow commands, you cannot give them glucose by mouth. Full stop. So reassess the patient frequently, provide transport. Now, the presentation of hypoglycemia, seizures. Consider hypoglycemia or an underlying condition. Ensure the airway is clear. Place the patient on their side. Put nothing in the patient's mouth. So for your seizure patient, don't try to restrict their movement. They can't control it. You can't control it physically either. Don't put anything in their mouth. When they're having a seizure, don't put any shoes over their nose. Don't beat them with any Bible. None of that nonsense. Let the patient have the seizure. Clear their environment. If you need to follow them in the environment, do so. I've seen a patient have seizure and move literally across the room. The seizure will stop. So there will be a point where they go into what is called the post-ictal state. This is where you will work and work efficiently. So this is where we clear the airway. This is where we put the patient on their side. This is where we make sure that we clear the suction the airway as needed. This is where if oxygen is required, it will be administered. This is where if a paramedic needs to give a medication that is going to stop the seizure, this is where it's going to occur. At no point we are going to give a medication when a patient is having a seizure. That's dangerous. So we have to wait on the post-ictal state. Very important. For altered mental status, which is common with low blood sugar, can be present with high blood sugar as well. May be caused by diabetes complication. Use your mnemonic AEIOU tips. Homework, find out what all of that mean. Always suspect and check for hypoglycemia in a patient with altered mental status. So a common acronym that is used for altered mental status is the AEIOU tips. Do some additional reading on it, find out what it means or what it represents. For your altered mental status, ensure the airway is clear. Be prepared to provide artificial ventilation and suctioning if the patient vomits. Provide prompt transport. Misdiagnosis of neurologic dysfunction can occur. Symptoms are often mistaken for intoxication. Misdiagnosis. A diabetic patient confined by the police is at risk. Look for emergency medical identification bracelet, necklace, or card. Perform blood glucose tests at the scene if protocol allow, or ED. Diabetes and alcoholism can coexist in a patient, and a patient doesn't have to be diabetic to have a low blood sugar. So just keep that in mind. And that's why I keep emphasizing that if you have a patient and the patient cannot tell you sensibly what's going on, and family members or bystanders cannot tell you exactly what's happening, ensure that you incorporate pulse oximetry, pupil reaction, and a blood glucose reading in your vital signs. Very important. Now, relationship to airway management. Patients with altered mental status can lose their gag reflex. We have learned this much from our airway management lecture. They can vomit or the tongue may obstruct the airway. Carefully monitor the airway. Place the patient in lateral recumbent position. If indicated, make sure your suction is available. All right, now let's look at hematologic emergencies. Hematology is the study of blood-related diseases. There are 4 disorders that can create a pre-hospital emergency. Sickle cell disease, which means that the red blood cell has a sickle shape, so it's not completely round. It has a sickle. A sickle is an equipment that they used to cut hay with on farms way back in the days. Right? So sickle cell disease means that the cell, the red blood cell, is abnormally shaped. It's not round, nice and round anymore. Because it's not nice and round, it cannot hold the oxygen molecules that it needs to bind to. So it's not properly oxygenated. It is not moved around effectively in the plasma either, so it can go places and get stuck. And the cell doesn't live for long. It doesn't stick around for very long. They die very quick. Hemophilia, bleeding disorder, thrombophilia, clotting disorder, anemia, issues with iron, issues with the red blood cell. So the blood is made up of 4 components: red blood cells, which is your erythrocytes. They contain hemoglobin, which carries oxygen to the tissues. Then you have your white blood cells, which is your leukocytes. They collect dead cells and provide for their correct disposal. So white blood cells are important to fighting infection. Platelets are essential for clot formation, and plasma serves as the transportation medium. Now, sickle cell disease is an inherited disorder. It affects the red blood cells. It's predominantly in people of African, Caribbean, or South American ancestry. It's a mishap in RBC. So again, it's not properly shaped, and it leads to dysfunction in oxygen binding and unintentional clot formation. Sickle cell disease, sickled cells have a short lifespan, which I mentioned earlier. These cells don't live very long, resulting in more cellular waste products and contributing to sludging of the blood, so the blood doesn't move very well. Complications include anemia, gallstones, jaundice, splenic dysfunction. And gallstone is the body is not removing waste properly, so the waste start to form crystals. Jaundice is liver issue. Problems with the liver. Splenic dysfunction is going to be a problem with the spleen. Now, sickle cell disease can lead to vascular occlusion with ischemia. I remember the term, the ischemia mean reduced blood flow to a particular area. And this can lead to acute chest syndrome, so they can actually present like they're having a heart attack. They're at risk for stroke. They can have joint necrosis, that's rotten. Necrosis mean rotten, because the blood vessels in the joints are so small. Pain, crisis, acute and chronic organ dysfunction and failure, retinal hemorrhages, and they're at a high risk for infection. Many of these complications are very painful and potentially life-threatening. All right, now let's look at clotting disorders or bleeding disorders. Hemophilia, rare. Only about 20,000 Americans have the disorder. Hemophilia A affects mostly males. These are patients who have issues with their blood clotting. So this is decreased ability to create a clot after an injury, which can be life-threatening. Patients can be prescribed medications to replace missing clotting factors. So usually it's caused because a clotting factor is missing, which when they get this clotting factor, it will release stored clotting factors or prevent the breakdown of blood clots. Still on hemophilia, common complications of hemophilia A include long-term joint problems that may require joint replacement. They are at risk for bleeding in the brain. They can develop clots from treatment. Now let's look at clotting disorders. Thrombophilia. Disorder in the body's ability to maintain the smooth flow of blood throughout the veins and the arterial system. The concentration of a particular element in the blood creates clogging or blockage issues. Still on thrombophilia, general term for conditions that result in blood clotting more easily than normal. So these patients have too many clots in the blood. And if the clots are forming in their lower extremities, they're at a high risk for pulmonary embolism. They're at high risk for heart attack. They're at high risk for stroke. So they spontaneously develop clots. Now, one of the things that they can have is a deep vein thrombosis or DVT. It's common medical problem in sedentary patients and in patients who have had recent injury or surgery. So DVT can develop in persons who are ill and they're not moving around much. It can develop in persons who are taking long trips, long flights. It can develop in females who are on certain types of birth controls, can put them at risk for clots developing. So there are various methods to prevent blood clot formation. Some of these methods include blood thinning medication, compression stockings, mechanical devices. Now, risk factors for DVT: joint replacement surgery, remaining sedentary for long periods of time. And that is why when certain patients have come out of surgery or they're in old age homes where they can't move on their own, they have to be turned, right, at certain intervals. We don't want clots forming and we don't want the skin to break down as well. Now, treatment for DVT: anticoagulation therapy. Medications are typically administered for at least 3 months after diagnosis of a DVT. A clot from a DVT can travel from the patient's lower extremity to the lung, so they are at a high risk for developing a pulmonary embolism if the DVT is dislodged. So when you're moving around with these patients, you have to be very careful. You can't slam the stretcher. To take time drive with these patients. They're at high risk for PE. Right, now anemia means that they don't have enough RBCs. So it's an abnormally low amount of red blood cells. The blood is unable to deliver adequate amounts of oxygen to the tissue. As a result of that, the pulse oximetry may indicate an adequate saturation even though the tissues are hypoxic. Very important point. So if it's one oxygen molecule on the RBC, the pulse oximetry can pick that up and say that the patient is properly oxygenated. And this is why we don't treat our equipments. Our equipments are there as a guide. We look at the patient presentation and we manage what is presented. Now, your patient assessment for these patients. Scene safety, scene size up. Most sickle cell patients will have had a crisis before. Wear gloves and eye protection at minimum. Consider ALS support if necessary. After your scene size up, primary assessment. Perform cervical spine immobilization or spinal motion restriction if necessary. Form a general impression of the patient and the environment. Assess airway and breathing. Inadequate breathing or altered mental status, consider high flow oxygen at 12 to 15 liters per minute via non-rebreathing mask. They're having ventilation issues, then you need to consider breathing for the patient. Still on your primary assessment, still on airway and breathing, sickle cell crisis patients may have increased respirations or signs of pneumonia. Manage respiratory distress. After the ABC's assessment, after the AB, airway, breathing assessment and management, next is the circulation. Sickle cell patients will have increased heart rate. Suspected hemophilia patients can be alert. For your suspected hemophilia patients, definitely be alert for the signs of acute blood loss. Note the bleeding. Note bleeding of unknown origin, and be alert for signs of hypoxia. Make a transport decision. So after your ABC's assessment and management, what is your patient's GCS? Can check the pupils at that point if you want to. Is it a load and go patient? Do you need to do a rapid scan or focus? After you package a patient, if the patient is communicating, then we want a history, OPQRST. Then vital signs will follow in the secondary. The patient not communicating, then you move up your vitals, consider physical findings, make sure you include pupil, pulse, oximetry, and GMR reading. So investigate the chief complaint. Obtain a history of presenting illness from responsive patients, family, or bystanders. Physical signs indicating sickle cell crisis would include swelling of the fingers and toes. They can have priapism, which is a painful, sustained erection. So it's a penile erection that is painful. They can have jaundice, which is liver, problems with the liver. Ask about single location or felt throughout the body. So ask if they're having any pain at a specific location or it's felt throughout the body. Ask about visual disturbances. Is there nausea, vomiting, or abdominal cramping? Is there chest pain? Is there shortness of breath? Obtain your sample history from responsive patient or family member. Have you things to consider or ask? Have you had a crisis before? When was the last time you had a crisis? How did your last crisis resolve? Have you recently had any illness? Any unusual amount of activity or stress? After your history taking, then we go to the secondary assessment, physical examination. Focus on major joints, evaluate and document mental status using your AVPU, vital signs, obtain complete set of vitals, and compare that to your primary assessment findings. Look for signs of sickle cell crisis, use pulse oximeter if available. After the secondary assessment, reassess vital signs frequently. Evaluate interventions, adjust or change the interventions as needed, document each assessment finding. Communicate with the hospital staff for continuity of care and document clearly, proper documentation. Now, specific emergency medical care for hematologic disorders. The care that we will provide for these patients will mainly be supportive care, and it will be based on their symptoms. Patient with inadequate breathing or altered mental status, we will consider administering high flow oxygen, 12 liters as a starting point, can go up to 15 with a non-rebreather. Place in a position of comfort, transport rapidly to the hospital. And that would bring us to the end of this chapter.